Good evening, everyone. How's everybody doing today? We're gonna wait a couple of minutes and just let people continue to trickle in. Um, so just bide with us as we let a little couple of individuals continue to stroll into our virtual conversation. We're so excited to talk to you today about the National Mental Health Policy and the Suicide Prevention Framework.
Hi, Chime. Good evening. Good evening, everyone. Thank you so
Good evening,
much.
Aisha. Glad to be here and glad to have you as one of our speakers for today.
Likewise, likewise. Thank you. I'm looking forward to learning from everyone and, also listening in on understanding the policies surrounding suicide prevention framework. Thank you so much for the invite.
Sounds great. So, as we continue to wait for people to trickle in, we're going to play a video a little bit about the work that Nigerian Mental Health has been doing, and a little bit about the issues that are going on in Nigeria. So, hold on for a second as we start this video to give a little bit of context about our conversation that's going on today.
World Mental Health Day is celebrated every year on October 10. The theme for this year, set by the World Foundation of Mental Health, is Mental Health is a Universal Human Right. The majority of suicides worldwide are related to mental health conditions. Currently, attempted suicide is deemed illegal under Nigeria's criminal and penal codes, carrying a 1 year jail term as a penalty. It's crucial to recognize that individuals who attempt suicide are often in a fragile mental state and require support, not detention or imprisonment.
So I like to say categorically that this is against the global best practice. What we have seen according to WHO in the early 19th centuries, where a lot of countries came up with punishable measures for people who attempted suicide. However, again, in recent times, we've seen that over 50 countries and many more countries have again reviewed these laws, and hence I want to say Nigeria, it is time we follow suit. It is time we decriminalize attempted suicide and look inwards to providing more support and more care for Nigerians to be mentally healthy.
Another reason why we must decriminalize attempted suicide in Nigeria is because it's a colonial law that was passed to us by our colonial masters. They have decriminalized this law since the 1960s. I wonder why we still hold on to it. We need to decriminalize attempted suicide so that those that need the help can get them.
It's important that we decriminalize attempted suicide to support our recently enacted Mental Health Act. Nigeria made history by passing the first mental health reform post-independence, which supports those persons with mental health conditions with a new terrain of human rights. But if we're going to make good on the promise of the Mental Health Act, we need to make sure that there's other critical regulatory reforms to support the community. One of those reforms would be decriminalizing attempted suicide. According to the World Health Organization, it says that those who have a mental health condition don't want to engage in seeking help from their friends, their families, and professionals because suicide is currently criminalized. To make good on the promise of the Mental Health Act, we need to make sure we decriminalize attempted suicide so those who have mental health conditions get the support that they need.
When suicide is considered a crime in a country, it actually increases suicide rates in that country, especially in women. One of the largest studies conducted by BMJ Public Health Journal actually found in correlation this criminalization of suicide and suicide rates, so that countries that had criminalization of suicide recorded more suicide rates in that country, especially for women.
One of the issues of the criminalization of attempted suicide is stigmatization. The disapproval that comes with being labeled an ex-convict, a permanent criminal record, and the feeling of shame and embarrassment. These are some of the issues that people deal with. It affects their human rights in areas such as access to healthcare, finances, and housing.
You can support this movement of decriminalization by joining thousands of others who have already signed our petition, available on www.nigerianmentalhealth.org, or by following the link in the description below.
World Mental Health Day is celebrated every year on October 10. The theme for this year, set by the World Foundation of Mental Health, is Mental Health is a Universal Human Right. The majority of suicides worldwide are related to mental health conditions. Currently, attempted suicide is deemed illegal under Nigeria's criminal and penal codes, carrying a 1-year jail term as a penalty. It's crucial to recognize that individuals who attempt suicide are often in a fragile mental state and require support, not detention or imprisonment.
So I like to say categorically that this is against the global best practice. What we have seen according to WHO in the early 19th centuries, where a lot of countries came up with punishable measures for people who attempted suicide. However, again, in recent times, we've seen that over 50 countries and many more countries have again review these laws, and hence I want to say, Nigeria, it is time we follow suit. It is time we decriminalize attempted suicide and look inwards to providing more support and more care for Nigerians to be mentally healthy.
Another reason why we must decriminalize attempted suicide in Nigeria is because it's a colonial law that was passed to us by our colonial masters. They have decriminalized this law since the 1960s. I wonder why we still hold on to it. We need to decriminalize attempted suicide so that those that need the help can get them.
It's important that we decriminalize attempted suicide to support our recently enacted Mental Health Act. Nigeria made history by passing the first mental health reform post-independence, which supports those persons with mental health conditions with a new terrain of human rights. But if we're going to make good on the promise of the Mental Health Act, we need to make sure that there's other critical regulatory reforms to support the community. One of those reforms would be decriminalizing attempted suicide. According to the World Health Organization, it says that those who have a mental health condition don't want to engage in seeking help from their friends, their families, and professionals because suicide is currently criminalized. To make good on the promise of the Mental Health Act, we need to make sure we decriminalize attempted suicide so those who have mental health conditions get the support that they need.
When suicide is considered a crime in a country, it actually increases suicide rates in that country, especially in women. One of the largest studies conducted by BMG Public Health Journal actually found in correlation this criminalization of suicide and suicide rates, so that countries that had criminalization of suicide recorded more suicide rates in that country, especially for women.
One of the issues of the criminalization of attempted suicide is stigmatization. The disapproval that comes with being labeled an ex-convict, a permanent criminal record, and the feeling of shame and embarrassment. These are some of the issues that people deal with. It affects their human rights in areas such as access to healthcare, finances, and housing.
You can support this movement of decriminalization by joining thousands of others who have already signed our petition, available on www.nigerianmentalhealth.org, or by following the link in the description below.
Thank you guys so much. And thank you for everybody who has showed up today for this important conversation around understanding the new National Mental Health Policy and Suicide Prevention Framework. We have an all-star lineup to discuss this issue today. And first, let me introduce myself. For those who don't know me, my name is Chime Esonye. I'm a Juris Doctor, and I'm the founder of Nigerian Mental Health. And you're just hearing about some of the work that Nigerian Mental Health does in the video that you saw earlier today. I'll tell you a little bit about Nigerian mental health. We're a global community of mental health practitioners and persons with disabilities. We have over 30, but now it's actually over 40 organizations focused on improving mental health in Nigeria and the diaspora. We're founded in 2019 to really connect individuals through our communities and partnerships to leverage our shared resources and knowledge. We have 4 primary policy objectives. The first one is to connect Nigerians actively focused on advancing mental health. The second one is to amplify and strengthen members, individuals, network initiatives. And so that might be volunteering, promoting, sharing best practices. Another one is increasing awareness and knowledge of resources on Nigeria, Pan-African diaspora mental health. And so we make sure we're updated on everything that's going on. For instance, recently there was one of the first Reuters article, which is an international publication, that actually talked about a major swimmer in Lagos, spreading awareness to suicide awareness, and makes us all aware of some of the key pertinent facts that are going on in mental health in the country. And then finally, conducting programming focused on transforming and making very sustainable change in Nigeria's policy landscape. If we get people together, we're able to do bigger things together. We have actually 4 areas of programming, or 3, which is policy advocacy, the work we've been doing, helping author and helping implement the National Mental Health Act, and now the Suicide Prevention Framework is part of that. Data and information, which means collecting information, doing psychosocial studies about the different mental health interventions that are going on in the country, releasing policy brief. Wellness, if you check on our website, you'll see information focused on wellness and programming and the different things that we do, whether it's walks or candlelight conversations to enhance people's personal well-being. You also saw earlier a lot of the different actors that are involved in Nigerian mental health talking about one of the big things that we're working on right now, which is decriminalizing attempted suicide. And we're really glad that federal government of Nigeria has helped put a framework in place to make this possible. And this goes to our next bit of objectives for today. So we have 3 primary objectives for this conversation. The first one is that people may not know April is actually National Stress Awareness Month. And so when we talk about stress, we talk about depression, we talk about anxiety. These are some of the biggest preponderance of the burden of mental health. So in honor of that, we wanted to make sure we highlight some of the ongoing reforms that are going on in the context of psychosocial well-being in the country. And then next month is a huge month for those who are mental health advocates. It's Mental Health Awareness Month all month. And so in preparation of the different events that are going to go on in May, we should know about some of these national reforms. Second, we want to discuss what's going on. A lot of people don't know there's a new administration, but what is portended is one of the biggest changes in any social issue that's going on in the country today is related to mental health. So we want to discuss some of these major reforms for psychosocial well-being that are occurring in the Nigeria's landscape. And third is that a lot of the people who know about the new mental health policies are individual stakeholders. And we wanted to make sure that we spread this out. And so there's larger public awareness, not only in Nigeria, but abroad, about what's going on with the mental health policies that have recently passed in November 2023. So these are very cutting edge. These are very new. Let's understand what they have to do. Let's understand what they entail and how they actually can impact our individual lives. So how would this conversation go today? This is a little bit of an overview. There'll be goodwill messages from our partners in crime, our collaborators from the Federal Ministry of Health. They'll talk a little bit about how we got here and a bit about the policy thrust, especially the mental health policy. And then we have to situate this in context. Mental health challenges or conditions happen to people. And so we have individuals here that'll share a little bit about their personal testimony, their personal mental health experiences. We'll talk about the 2 policies. We're likely going to switch the order. And instead of talking the national mental health policy first, we might talk about the suicide prevention policy before that. We'll have a group picture. We'll let the audience ask some questions and answers, and we'll go to next steps. So that's how the session is geared to go. And so we have one of the main individuals, not the main individual who is helping push national reforms in the country. And as a matter of fact, when Dr. Tunde Ojo came on as a national coordinator for the National Mental Health Program for the Federal Ministry of Health, we started seeing reforms buzz and push. And so we're really excited to have him talk today about what's going on with mental health in Nigeria and offer some goodwill remarks. Dr. Ojo, are you there?
Yes, I am. Thank you. Good to be here. Thank you.
Please, thank you so much. And we're happy to hear from you.
Okay.
Can you, there we go. Let me stop sharing my screen. I don't know if, and I think that might help.
Well, are we, am I starting now? I thought you were just going through the, I thought you were just going through
No. I wanted you to start with goodwill message, sir.
Okay, so I think I have just like 5 minutes, right?
5-10 minutes, sir. And if you can turn on your video.
Momentarily, right?
Sure.
Okay, good evening, everyone. Yeah, happy to be here. And then also, Chime, Asanya, and your team, great job. Well, I'm not the one driving the reform. The federal government has created the platform to drive the reform because you can't stand something on nothing. And so I believe that the biggest that the government has done and an indicator that the government is serious about mental health is moving it from a desk to a division on its own. And so, well, I'm not driving it. I think it's all of us here in this room, all stakeholders and beyond now. And I know that when we come together, then we begin something good. And when we stay together, then we can go a long way. And I think that has been the spirit in the last 2 years. And of course, the Nigerian mental health has been very, very strategic in this. And we appreciate you for what you're doing. And I must say that it's a very humbling time for us as a program and as a country. Yeah, the National Mental Health Program was established March 2022, and March 2024 we celebrated our birthday, if there's anything like that. So we are 2 years as a division, and honestly, how time flies. And 2 years is gone, but we are very happy for the modest achievement that we've been able to record as a program and by an extension as a country. And let me say that what we've been able to do in the last 2 years is more of a social experiment. We've come into this space as new, and then we've seen the organized CSO, oh, come on, let's see, what's new? Are they going to do something? So there were bystanders, there were people that were standing, that were standing afar off, so to say, oh, can anything good come out of government? And then there were very sincere stakeholders, that said, let's push these people and let's see how we can get something out of this. And anything that the government brings out is for us. And so it was now more of positive energy. And of course, well, what has happened in the last 2 years has been, like I said, a social experiment of building trust among partners for development of mental health and having very frank conversations on how things should be. And I will also say that we came into office with a very clear objective, we knew what we wanted to do, but it's always also been a learning curve for us. We knew what we wanted to do, how to do it. It would take a lot of input from people, and that's our mantra wherever we go. We have a sense of direction of where we want to go. How are we able to do it? We don't know in totality, and we are learning on this. And stakeholders like Nigerian Mental Health Group, the Professional Association, CSO have come on the table and said, this is her business. And of course, things have changed. We have the National Mental Health Policy. We could sit down to talk about this now. We have the National Suicide Prevention Strategic Framework. We organized the first ministerial roundtable on mental health. We've been able to integrate mental health into NTD. We have things coming up in the HIV space, integrating mental health into HIV care in Nigeria. I mean, there are quite a lot of conversations that are going on. And mind you, this is in the midst of paucity of resources. But the thing is, money should not be the first thing on the table. We have vast human resources in the space, ideas, and I think this is what has driven us. And thank you, everyone, for your support. And with you, we can do so much more. Let me end by saying that of course, the MH gap. Yeah, if we do good, we should talk about it. So the MH gap, which is a WHO document for scaling up mental health in resource-constrained setting, the newest version came out in November 2023. And I must say that ending the first quarter of 2024, Nigeria again made history by being the first country to contextualize the new MH gap. What that means for us is the MH gap is for bridging resource gap. And so we are leading in the pack in that. And we know that these things are coming out. It is for us as a government to give direction, and then off-takers, stakeholders to be able to say, what can we do? How can we drive this on? And which I think is the next thing. And I also know that this is what Chimane and his group are doing. Let's continue this conversation. Are we where we should be? The National Mental Health Act is there. We have been developing roadmap. Where are we going to go? How do we go about that? The Suicide Prevention Strategic Framework, what are the actionable things? Conversations need to go on everywhere. It doesn't have to be driven by government, but there must be productive conversations, and that we signpost us into what are the next things that should be done. So I'm very happy to be here tonight. We'll be part of the conversations, and I can lend my voice to one or two things as the conversation emerges. And I must say that I'm not the only person here. In the spirit of learning, I'm just not here to represent the government, but I asked some of my team members to be here so that we listen, we glean from the discussions, and then it can also be an agenda for us on what are the next things for us to push. But I must say that mental health is everybody's business. Mental health is serious business, and we have quite a lot of order for us to scale through. So if it seems that you're not seeing so much traction from us, the truth is there are quite a lot of barriers that we have to push through behind the scene that you may not see. But I must say that it's the beginning of a journey, and we have made significant progress. But the truth is, it's not yet uhuru for us. Thank you so much, everyone, and I welcome you all.
Thank you so much, sir, for those beginning introductory remarks. Let me try to remove the pin and then share my screen again. So what we're gonna do, what we're gonna do now is that after we have some context in terms of the reforms, and I think that a lot of you may not know about MHGAP. MHGAP is an amazing WHO tool that is being used in developing country contexts. And so him saying that Nigeria is beginning to domesticate it and is leading the way of that is actually a very big deal, because it's one of those things that we have theory around policy and strategy, but then we have the training, the tools, and what actually individuals who are in the mental health space connect with. So that's a really amazing conversation about what's going on, and hopefully we'll hear about it more today. So instead of going to the mental health policy, let's start with, since we already saw a video concerning suicide, let's actually start with suicide prevention and challenges. And so I'm gonna go to Aisha, actually. Aisha Sambo, if you're there, if you could, who's a founder of the Mind Over Matter podcast, if you could share some of the personal experiences you've had concerning suicide, attempted suicide, suicide prevention, to really ground this conversation in what people are experiencing. So, Aisha, if you could come on, if you could come to the center stage.
Hi, Chime. Good afternoon, everyone. Thank you for that introduction. My name is Aisha Sambo, as Chime already introduced, and I started an awareness campaign actually in 2019 together with my friends and in collaboration with NIM Foundation. NIM Foundation is an organization based here in Nigeria that offers psychological and psychosocial support. And I found them quite interesting because they were gearing towards an area that a lot of people were not looking at, and that is rehabilitating some of the Boko Haram victims. Right. And I want to speak a little bit specifically about my own personal experience, just dealing with, my own mental health and challenges. So in secondary school, believe it or not, little old me was suicidal. And I say this now with so much growth and, progress in terms of how I now deal with my own personal mental health. It's not to say that I was, um, what's the word? I'm trying to pick my words carefully. It's not to say that I was suffering in the sense that I didn't go to, a poor school. I went to a very good school in Nigeria. I'm not from a family where I was, so to say, being abused or nothing like that. I simply was a very sensitive child. And going into secondary school, you get to these sort of terrains where really, I'm just going to say pop and plain, Hausa girls can be mean. They can just be so mean. And when I say Hausa girls, this is not particular to, I'm not generalizing, I'm just saying in a group, especially in secondary school, I find that Hausa girls can just be so mean, when they're in cliques. And so I struggled with that. I struggled with really fitting in. And for me, I would say family support really helped. How did my family get to know about this? They found out from the school nurse. I tried to do some funny things and I was not successful. Leading my aunt, may her soul rest in peace, Dr. Mrs. Mariam Babangida. I remember her driving to the middle of El Amin International School Square. So I went to secondary school in Niger State. And I remember her driving to the middle of the school very angry at me, and she targeted it at a very at a very good time, at a time where everyone was in school. They were playing sports. She drove into the middle of the square, opened her boot, said, "Oh, I heard what you were trying to do. Please, I'd like you to just leave. Let's go home. Since you're not happy here, I don't know why you're not happy here." And truly, it took some counseling, it took some self-reflection. My family really helped as well. I would say I got a lot of support. um, and I think more schools really need to have counselors that actually are trained to understand children's needs when it comes to adjusting. I just remember secondary school being a very tough period of my life, feeling like the weight of the world is on your shoulder. And what helped was journaling. I kid you not, I've kept all my journals from when I was in secondary school, and revisiting those journals now, I laugh. I laugh at the fact that, little things like, oh my God, I'm so worried about walking into the dining room and all the boys, shouting or yelling my name, calling my attention. These were the things that triggered me, and led up to so many other issues within me. And this is not the first time I've also spoken about this. I have friends at Gatefield TV. I think now it's called Gist TV. And I gave a testimony as well about, my own experience dealing with suicide. So for anybody that's watching this, that is, contemplating suicide, I just want you to know that, your life does not end, like your thoughts and your ideas should not just end in your head. A lot of the times you don't get to see clearly if you're just going through it alone in your head. And that's why I really encourage people to journal. Who would have thought that a year after me campaigning for mental health advocacy, we would end in a pandemic where I say this, I feel mental health, mental illness is the next pandemic, so to say. And we really need to put our foot down to say, it's not okay that in a country like Nigeria with so many beautiful, talented creatives, why do I say creatives? Because I feel like creatives have it the most. The creative industry is an industry where, not a lot of people invest in so quickly, because it's one of the riskiest. And so you find a lot of creatives struggling to really just make ends meet. Um, Maybe I'm too passionate about this because I'm a creative myself. And as we know, we are very much more heart than analytical. And so it's very easy for triggers to get to us, triggers of criticism, triggers of, not feeling like we're where we're supposed to be. And so for me, that's just my own little testimony. It's great to see Dr. Tunji Ojo on this call. I actually personally reached out to him on talks about trying to plan a mental health, a youth mental health conference. And it's so glad to see you, sir, today in the space. Chime and I have been in conversations for many, many years. We help each other. And so I don't want anybody in this group to feel like, they're alone in what they are advocating for. This is our project, this is our country and our lives. And for the future of young people, I think it's high time that we all start speaking up about the truth of how our society can be judgmental, the truth about how our society can sometimes be very harsh and critical towards cultural dynamics. And so I just hope that, moving into the next century of what this great country Nigeria could be, we begin to really decriminalize suicide, yeah, and we should all try to prevent it. It's not worth it, even from a spiritual point of view. I'm just gonna end here by saying, because I believe Nigeria is a community where we are very much spiritual, and so if you believe in God, just know that suicide is not the way. What are you gonna tell God when you get there? Yeah. So thank you so much for that. Thank you, Chima.
Thank you so much. And there were so many things in what you said that I think bear repeating. So one of the things that you mentioned was around a upcoming mental health conference focused on youth. And so that's something that we should that's something that we should that's something we should stay tuned and we should pay attention to. I think that was very, very key, and I'm looking forward to working with you and other partners on that. You also mentioned other things that I thought were important concerning how we're a prayerful, faithful culture, also that people can exercise judgment. And I think that people really got from your story that it's okay not to be okay, and the different resources that need to be there. For instance, in schools, with nurses, or just the way we think about issues and challenges when it comes to mental health conditions. So it's not as judgmental, and we give people the right resources and tools that they need. So thank you so much for sharing your story and being vulnerable to talk about the challenges you're faced when it comes to suicide. And so now that we hear that personal testimony, I think let's hear about how the government and other stakeholders have collaborated to respond to this particular issue. And we have a very special doctor in the house, Dr. Atilola, who's a senior lecturer at an honorary consultant psychiatrist at the Lagos State University Teaching Hospital, LASUT, and which has been doing a lot of work for years around mental health. Oh, we have a thought. Sa, Dr. Ojo, you have your hand up.
Yes, I wanted to quickly correct an impression. Yeah, so
Sure.
Dr. Olayinka Atilola is a full chair. He's a professor. So I didn't want to pull down your this thing. So, but I think it's not a small feat, and so you have downgraded him by two positions. So please let's address him appropriately. Thank you.
Okay, thank you so much. So, Oga full professor, full stop. If you can please make your way to the stage, and so we can talk to you and hear about the suicide prevention framework that you've done so much work on, and we're so excited to hear about what Nigeria's experience has been to that. So if you can come to the front of center stage, I'll stop sharing and I'll pin you, and then also you can share your screen, sir. Are you there?
Yes, I'm there. Thank you very much.
Well done, sir.
Okay,
Professor.
let me try to.
And can we make sure that he can share his screen? He should be able to. If you have any troubles, let me know.
Yeah, I think I can share my screen. I thought I have. So good evening, everyone. As earlier introduced, my name is Olayinka Atilola. Dr. Ojo quickly tried to intervene by mentioning that a professor of psychiatry, which is correct. I work in Lagos State University, and I'm also an honorary consultant psychiatrist to the Lagos State University Teaching Hospital. Trying to get around the sharing. Okay, yeah, I think I'm good now. My understanding of what I'm supposed to talk about today is just to give an overview of the National Suicide Prevention Framework, which is not a tentative document anymore. It's already an official document of the Federal Ministry of Health. And what I will just be talking about is the background to the document and some of how the document came to be and some of the highlights of it and the lessons we can take away from there. I don't know how long I have, but I will try to make it brief. I will start from a background. Many of the things I'll be talking about here are things you already know. Globally, almost 1 million people take their own lives every year, and many more people attempt suicide. Of course, those who die by suicide, a lot of them are drawn from people who have had suicidal attempts or in the past, or even in the index case, there are attempts that ended up being successful. And it's listed as the 10th leading cause of death globally across all age groups. And particularly within the age bracket of 15 to 29 years, which is the predominant age group in Nigeria, it is the 4th leading cause of death. It's competing seriously with road traffic accidents among young people. And every suicide is a tragedy that affects families, communities, society, and has a long-lasting effect on the people left behind. Suicide is never, death by suicide is never anything envisaged by family members. It always comes as a surprise. It throws everybody off balance. It's one of the most traumatic ways that anybody can die. And the families left behind suffers a lot of emotional difficulties beyond the death. We did a citywide household survey in Lagos in 2018, and the study involved more than 11,000 participants, sampled in more than 1,000 households in Lagos. And we recorded a weighted prevalence rate of 7.3% of current suicidal ideation among respondents. What I mean is that during that index period in 2018, when we're doing this study, 7 out of every 100 people living in Lagos is dealing with a suicidal thought at varying degrees. Of course, in the study, we broke it down into different stages of suicidal thoughts, but this is overall 7.3%. That is a very large number. We will later see in the course of this conversation why that number is important, because suicidal idea, often than not, is the precursor of death by suicide, because suicide is like a process, and there is a point in that continuum of process that is an idea. Then it later may become an attempt. So there is a pool, a 7.3% pool of people that are potential suicide attempters. That's what that study is saying. That is almost an emergency. Thankfully, with advocacy in Lagos then, we're able to use this singular study to make a case. And the Lagos state government employed 5 mental health practitioners, and I'm talking about psychiatrists, in 5 different general hospitals across the 5 geopolitical zones in Lagos in response to that. And I think that is something that is the power of data. When there is data and data is being presented to the right people, sometimes you can get some of these things to change. And the rate of suicide in Nigeria has been put at 15 per 100,000 population, which is higher than the average for Africa. And the country lays along the so-called suicide belt of the world. So bottom line is that suicide is a problem in Nigeria more than it is in many parts of the world, whether we acknowledge the data or not. So what is the rationale for having a suicide prevention framework? Suicidal behavior places a heavy burden on the nation in terms of the emotional suffering that families and communities experience, the economic cost associated with medical care for attempted suicide. One of the big issues with suicide attempt is that you attempt, yes, you didn't die, but you probably spent 7 days in the hospital, 2 months in the hospital. People have spent a week in the intensive care unit, paying 100,000 naira per night. The cost is huge. And then there's loss of productivity to both the suicidal behavior and the death that comes with suicide. These are issues that should make a country to say, let's sit down and draw a plan. So that is one of the rationale behind the suicide prevention framework. The other rationale is the fact that Nigeria is among the African countries that is committed to implementing the WHO Mental Health Action Plan 2013 to 2030. And on this plan are the following suicide relevant action plans: reduction of mortality by suicide under the SDG 3.4.2, and reduction of premature mortality from NCDs by 1/3 by 2030 through the prevention and treatment of and promoting mental health and well-being. So there is no way you want to meet this WHO mental health plan that has suicide-relevant action plans in it without having a strategic framework. No country just solve a problem by just taking incoherent and inchoate actions. You have to have a plan. You have to have a framework within which that plan is being hinged. Also, the new National Mental Health Act that was signed in Nigeria support the promotion of mental well-being and safety for everyone. So again, another good reason why we should have a framework. And finally, the Federal Ministry of Health, through the National Mental Health Program, has the mandate to catalyze and coordinate all stakeholders' efforts aimed at addressing mental health issues, including suicidal behaviors in Nigeria. So there are so many stakeholders, NGOs, different organizations trying to do something about mental health. Part of the responsibility or mandate of the Federal Ministry of Health is to see how they can catalyze and coordinate all these efforts together. Without a framework, without a policy, without a strategic plan, some of these things are not going to happen. So also another rationale is that suicide is preventable. And for every preventable affliction in this world, there is an action plan. You want to prevent transmission of HIV, there must be an action, a strategic framework for it. It's not just enough to say, oh, I've distributed condoms in all secondary school in Nigeria. Again, within which framework did you situate that your distribution of condoms, that you can now see how it dovetails into the prevention of HIV. This is the way it goes in public health. You have a framework for every issue that is preventable. And of course, due to the heterogeneity of the causative factors, the issues that come together that produce suicidal ideation are complex. And because of this complexity, actions that are geared towards preventing them must be comprehensive, must be multi-sectoral, must be integrated, and must be synergistic. And all these big English that I'm mentioning, you can't achieve comprehensiveness, multi-sectoralness, integration, synergy in preventing something without a strategic framework. It will just end up being incoherent and inchoate actions. Such strategy is best developed through multiple stakeholders, documented and integrated into policy framework at the National Health Authority levels. And that is what the National Suicide Prevention Framework is. Something that involves multiple stakeholders, that is documented, that is integrated into a policy framework, and is at the National Health Authority levels. And that is the way to go when you are trying to prevent any affliction, whether it is suicide behavior, or it is malaria, or it's HIV. That is the way to go if you want your strategy to be well scientifically informed and carefully implemented. So how did we develop the National Suicide Prevention Framework for Nigeria? It was developed through a consultative process that involved the Federal Ministry of Health, other relevant MDAs, the academia, professional health bodies, persons with lived experience, NGOs. Everybody brought their development partners, everybody brought their own expertise. FMOH provided us the platform. Other relevant MDAs provided us with strategic partnership. Academia, of course, which is what they do, they provided us with the science, the knowledge behind some of these issues. Professional health bodies being the people that are involved in the practice, in the field, the Psychiatric Association, the Psychological Association, the Social Workers Association, different organizations involved in mental health care. They provided us with the field experience, field reality, and persons with lived experience. Of course, in whatever you are talking about, you need people who can say, this thing has happened to me before. This is how I experienced it. These are the things that if I had, it would have made a difference for me. These are the things that failed me. These are the things that helped me, and all these things can be incorporated into a strategic framework. NGOs brought their experience on the field. Development partners brought their experience, their resources, their funds, and everybody came together in putting together this national framework. And the development process followed the MRC framework. There's something called the Medical Research Council framework for the development of underlying complex interventions. Whenever you have an intervention that is complex, you need to create a system whereby you have multiple stakeholders and you go through different levels of review to make sure that you have captured the thoughts of everyone. And this graphical representation just showed the developmental process. There was a theoretical development, which is let's sit down, let's develop the science, and then let's review together with experts. I was the lead of the theoretical development and expert review process. And we first sat down, we looked at the literature, we looked at what is being done. Nigeria is not the first country to have a national suicide prevention framework. So we were able to get other national suicide prevention framework from around the world, including in Africa. I think Kenya beat us. So they already have a framework. So many of these documents and the science around this were gathered together, and then we synthesized it together, and then we were able to eventually produce a zero draft, which we, after a review by 4 experts, it was now presented to the stakeholders for engagement. And who are the stakeholders? Those people I mentioned before: the Federal Ministry of Health, the MDAs, the NGOs, the academia, the professional bodies, everybody, the police, the media, everybody that is involved in the business of mental health and suicide prevention were called together, and we sat to review the document. And I can assure you that that process went on and on, different stages, there are things we had to rewrite, there are things we have to remove, to add, and all the thoughts of people, including people with lived experience, came into the document. And then we went through a finalization process, which is bringing all the thoughts different from what is contained in the zero draft, adding it to it, taking some out of the zero draft that may not have been well conceived, and then finally coming up with a document. And then we move to the validation stage, where we sat down again to look at the document steps, page by page, line by line, to see whether there might be anything that is still misrepresented or didn't really capture the essence. And then we finalized that, and then the document was now sent for final documentation, which is the print, and then adoption by the Federal Ministry of Health. Of course, it went through the whole adoption process and is today an official document of Federal Government of Nigeria that can be referenced, that can be used, that can serve as a template for anything related to suicide prevention. In the course of the drafting of this framework, we made some assumptions. And these assumptions, I call them assumptions, but they are true. That suicide is a process and not an event. What does this mean is that you don't just die by suicide one day. It's a whole process. And that assumption is important in any strategic framework, because what it suggests is that if something is a process, then you can truncate it somewhere along the line and make sure that you don't get removed, which is death. The risk factors, another assumption that was made, that the risk factors are variegated, meaning that they are multiple and complex, and they cut across several biological, psychological, social, environmental, and policy domains. And that any effective intervention strategy must be multi-layered and cognizant of these diverse risk and protective factors. And that leads me to this next slide, which is when I say suicide is a process, this is this basic assumption. People go through this process, and those who have had lived experience of suicidal attempt will tell you that they could recognize each phase. They may have spent only 1 week there, they may have spent only 1 month, they may have spent 1 year, but they pass through this day. The first is starting with being tired of life. Life is not just looking as interesting as it used to be, maybe because of some psychosocial burden or anything. Then they move to the point where they start wishing to die. And wish to die is different from suicidal idea. Wish to die, you are not planning to do anything to yourself, but you are hoping that something can happen to you. Those are the people that will be in a bus and the driver is speeding, everybody is shouting, they can't care less. Because in any case, they are not, they don't mind if they die. And they may not deliberately take risk, but they don't prevent risk. They just live their life. And then after that point, people may move to the point that we call suicidal idea. When the idea is going beyond hoping that you will die, but getting to the point of wondering whether you can do something to yourself, but you don't have any plan. You're just wondering, are there ways? Can I do this? And then move to the next stage, which is suicidal ideation again, but with a plan. By that time, the person has bought the sniper. People have bought sniper, kept it under their bed for 6 months. So meaning that they sat in that stage for 6 months. People have kept a knife somewhere in their room for 6 months. And they didn't pick it, but they kept thinking about it. That is suicidal ideation with plan. And then we have the suicidal attempt. That day when they decide to do something. And for those who didn't die, unfortunately, they can re-enter the cycle again. So they were treated, they got well, they go home, and they re-enter the cycle again as suicidal ideation without plan again. And then they move to with plan, and they move to suicidal attempt. And somebody can be cycling like that for a while before they get to completed suicide. And another person may just do it the first time, and that is it. Now, this pathway is just showing to us that this is a process, and that process is like a journey, and that journey can be broken. So, interventions for suicide prevention as contained in the framework now targets all the levels, including targeting people before they enter into that suicide pathway, and of course, targeting people in the course of the suicide pathway. They are already there, but you are preventing them from progressing, or you are reducing the risk of them moving to the worst outcomes, which is death. So 2 groups of people before entry, and those who are already there, how they will not progress. And when you are doing this intervention as contained in the suicide prevention framework for Nigeria, what we are saying is that interventions for either before entry or in the course can be directed at the individual, at individual level, the individual himself or herself, or at the community where that individual is living, or at the level of policy of government. And when you go through the suicide prevention framework, you come across some of these individual level interventions before somebody enters into suicide pathway. These are interventions that is intended to promote mental health and reduce the risk of suicidality. Every action that you do to promote mental health, to promote resilience, to promote well-being, to promote happiness will reduce entry into suicidal pathway. Fact. And these are usually, they are the easiest because you can deliver such interventions in groups, in large groups. You can deliver it to large number of people. You can deliver it to a whole school. You can deliver it to a whole church. You can deliver it to a whole community because you don't even want to know who is already there. You just want to promote mental health for everybody. The people that, from the data that we had, we said only 7% of people have suicidal ideation, meaning that when you enter an average community, 93 out of every 100 people have not entered the suicide pathway. Sometimes we forget them, we focus on the 7, but then individual level interventions that before the entry into the suicide pathway suggest that intervene so that people's mental health is promoted and they will not enter the pathway in the first instance. Of course, it's a different ball game for those who have entered, but all effort at promoting mental health also help people who have entered into the pathway to reverse back. And the setting can be school, universities. Interestingly, I'm happy to inform that the Department of Behavioral Medicine, Lagos State University, as led by one of our senior colleague, Professor Adeoye, of course, including myself, we recently got a grant from one international organization to do exactly this, develop a framework for individual level intervention that promote positive mental health among youth in schools in Lagos, to see whether we can develop it into a template that can be used in other parts of the country. We are using the youth aware mental health, the YAM, which is the internationally acclaimed framework for primary prevention of suicide among young people. Now, these are before entry. We are not going to be asking anybody whether they are suicidal or whether they are thought of suicide. We are just going to be delivering to everybody. That's an individual level intervention. And the things that can be there, emotional regulation skill, problem solving skill, interpersonal skill, mindfulness, stress management, safe use of social media, substance use education, all these things promote mental health among young people. And of course, sometimes, again, there are people who are particularly at risk. Those who have psychosocial issues, like people that are exposed to specific adversities, like victims of domestic violence, victims of sexual violence, people with HIV, people who have stroke, people who are living in unpleasant life circumstances like adolescent pregnancy, or people receiving social welfare services for whatever reason. These are at-risk group. They can also be a point of intervention before they enter into the suicide pathway. And all these things that I'm describing are the kind of essence that the National Suicide Prevention Framework already captured as a guide for interventions. And also, after the entry into the suicidal pathway, I mentioned that early identification and effective management of the early symptoms of suicidal ideation. Again, people have already entered into that pathway. They're already feeling tired of life. They're already feeling that they wish to die, or they already have suicidal ideations. These people, we need to avert their progression to worse form of mental health conditions. And those are people that need mental health services for whatever psychosocial issue was behind their suicidal ideation. And this is also part of the point where a crisis intervention telephonic service coming, because people that have suicidal idea with plan, they often talk to somebody about it. Sometimes we don't take it serious. So, and sometimes people don't want to talk about it because they feel that people may misunderstand them. A 24-hour crisis telephonic service that is anonymous, that is toll-free, people can be prevented from taking an action. And there are so many people that have reported around the world that an availability of the 24-hour line that they can call in their most vulnerable moments has helped to move back from suicidal ideation with plan back to a lower level of suicidal behavior, of which they can now be directed to the appropriate service, and you may just get somebody off the suicidal plate using that strategy. Community level interventions are things that are directed at community, and one of the biggest areas that is contained in the framework is interaction with the media for responsible suicide reporting. Every time that you see in newspaper, Mr. Deniji, 43-year-old, committed suicide in Ajah by hanging himself his ceiling fan, all these things, when they swarm the internet and the social media space and the media space, people get ideas, people that are already in suicidal ideation without a plan, because sometimes it's so difficult to come up with a plan. When they read those things, they say, oh, finally, I have seen something that somebody did. And then we talk about what we call the copycat suicide. People just use that as a fulcrum. So there is a responsible way of reporting suicide. This has its own entire framework, and many of these things are captured in the suicide prevention framework. And also community level intervention, limiting access to means of suicide. This table is showing that poisoning is the highest mode of suicide among females in Nigeria, and second highest among males after hanging. So meaning that any intervention at community level to reduce suicide among people who are already on the suicide pathway must involve control of poisonous substances and avoidance of anchor points where people can use to hang themselves. And there are different ways. Banning of acutely toxic and highly hazardous pesticide in Nigeria, it is a lot of work. You can buy sniper, you can buy any substance by just walking into a pharmacy, into a chemist or a shop, or even while driving in traffic. Limiting access to everyday pesticide, herbicide, installing barriers at potential jump sites such as bridges, restriction of prescription of highly toxic medicines, all these things are contained in the framework. And of course, at the level of the policy, there are some strategic objectives, which include to establish a suicide prevention governance structure in Nigeria. Anything that doesn't have a governance structure will just be there. And that's where we talk about things like having a national suicide prevention steering committee that meet from time to time to say, okay, where are we? A national suicide prevention technical working group at national and state levels. In fact, in the framework, in the national suicide prevention framework, we went as far as putting some kind of algorithm of how the governance structure will look like. A closer look at the document will show many of these things. It involved the Federal Ministry of Health, the National Council of Health, the State Commissioner for Health, the state mental health desk officers. Everybody is captured in some kind of governance structure that should direct how suicide prevention framework should go in Nigeria. And then another strategic objective at policy level includes to establish and strengthen policy, including legal frameworks such as decriminalization of suicidal behavior. We have talked about that extensively today, as well as to mobilize resources to operationalize the suicide prevention governance structure effectively. If you cannot have a governance structure and not have a funding plan, it will just be a governance full-fledged. Because if you don't have a funding plan or resources to make that to function, it's also an issue. So part of strategic objective is to develop and strengthen the policy legal framework, as well as to mobilize resources for all these governance structures, and to improve access to quality and integrated services for suicide intervention at all levels of care, primary, secondary, tertiary, community, everywhere, to increase awareness activities, awareness raising activities and advocacy. I know a lot of NGOs are doing very well in this area, but maybe what the strategic framework is saying that we need to coordinate a bit more under a governance structure for suicide prevention, and to strengthen research. I've told you in the beginning of this work how research can be powerful, and that is a fact. At least I am a living witness to that a single piece of evidence led to government approving the employment of 5 psychiatrists for 5 geopolitical zones in Lagos, having been presented with a very strong data, of which the State Ministry of Health was involved in the data gathering process. It was under the current NCDC Director General, Dr. Jide Idris, when he was Commissioner of Health in Lagos. And to strengthen surveillance, monitoring, evaluation, and suicide prevention intervention framework. Other components include the fact that roles and responsibilities of every stakeholder in the suicide prevention framework was clearly stated in the document. If you want to know what is your own role, find out what is your own name. Are you an NGO? You will see role. Are you a police officer? You will see your role in that document. And a comprehensive monitoring and evaluation framework was also included. So in conclusion, the National Suicide Prevention Framework for Nigeria establishes a framework for reducing the rate of suicide by putting together evidence-based, cost-effective program and health and socioeconomic interventions that change behavior and lifestyle and address the population at large, as well as vulnerable groups. It captures a whole series of activities ranging from environmental control of risk factors and means of suicide to early identification and effective treatment of people with mental health conditions, as well as provisioning of helplines. It is a veritable starting point for an organized, government-driven, collaborative suicide prevention program in Nigeria. This is the National Suicide Prevention Strategic Framework for Nigeria. This is the back page of the document as currently available. Thank you very much. You've been a wonderful audience.
Thank you so much, sir. So much. And honestly, there's so many things that you can stop sharing. There's so many things that you said, but I just wanted to highlight a couple of them. The first one is the importance of research in implementing future interventions. And so I think that there's a lot of people here that would be interested in doing research, and we would love to collaborate with government on the research you're doing, because one of the things you said is that when you did that research with the government bought into it, took those results, and led to change. It would actually be good if we could get that. So this one, about 7.3%, that was done in 2018. Nigeria Mental Health actually has a repository of research done on mental health. So it'd be great to get that from you so we can have it as part of our findings, the things that we can quote in the future. Would be really, really good. I think that I want to emphasize two other things you mentioned. One was a 24-hour crisis hotline that was called for in the policy. Very, very key. We have countries like in America, they have a 988, a national hotline, and that's where all the actors are committed. In America, it costs $1 billion for that effort. In Nigeria, we can do that for much, much less. So that's important. And then you mentioned again, other things that are in the policy, focus on decriminalizing attempted suicide and the different levels of intervention, individual, community, etc. So with that guy, can we give him a round of applause virtually or on your screen or in the chat for that really great presentation so far? We really appreciate it. And Sa, Professor, in case so I don't get called out by Dr. Ojo, I've already gotten questions personally and in my DMs about the slides, that people would really like to see those slides. Obviously, not everybody can go through the whole suicide prevention, so they would love to see your slides. I hope we can make that available to some of the individuals that attended this session.
Yeah, I think I sent it to the email that invited me to this program. I sent it ahead. I was thinking that I needed to send it, so I sent it earlier today. If you check your email, that's National Nigeria Mental Health email. It's there.
Yes.
Yeah, right.
Yeah. Yes. Thank you, sir. So I appreciate that. So with that said, we're gonna have an opportunity so people can ask him more questions. And I did see one comment already about Dr. Atidola said at the very end, he gave you a picture of the suicide prevention framework, and people asked, where can they access it? In the chat, if you check, we've sent a link where you can access the National Mental Health Policy and the Suicide Prevention Framework. To my knowledge, I might be wrong, to my knowledge, it's the only public place that I've seen that people can access those documents right now. So if you want to read these, the conversation, if you want to read these policy frameworks, please check the chat, click on that so you have that resource going forward in the future. And with that said, we've heard more of the policy, and I think let's get back to hearing more of the personal perspective of how this really impacts individual. And we have our next speaker who's going to talk very quickly, Madame Sotoye Okunlobo. who's the founder of the Sontaye Okolobo Mental Health Foundation, to talk about her own thoughts, personal experience when it comes to mental health challenges. And then we'll talk about the national mental health policy, and we'll let Dr. Ojo give us more guidance on that. So if Sontaye, if you're here, can you come on to the stage, the online stage?
Good evening. Good evening.
Good evening.
Can you hear me?
Yes, we can hear you.
Okay. Unfortunately,
okay.
There's no light here, so I can't turn on my video. I'm in Nigeria.
No problem.
So sorry. I have cough, but I didn't want to cancel, so I'm gonna do it. There's no light. Light is very bad right now in Nigeria, so bear with me, guys. Okay, so my name is Sotonye Okolobo. I'm a founder of Sotonye Okolobo Mental Health Foundation. I battled 3 mental health conditions for 20 years. The mental health conditions I battled were partial complex epilepsy, major severe depression, and borderline personality disorder. So first of all, I'd like to thank Chime for organizing this meeting. You're doing a very good job. Thank you so much for all the things you're doing in the mental health awareness field. Okay, so there are major 3 mental health challenges in Nigeria, and I'll bring that to my personal story. The first aspect is the financial aspect, the lack of financial support. When people have mental health conditions in Nigeria, most people don't seek help because they can't afford, hospital bills and all of that. But in my own case, that wasn't the problem because, my dad was the media manager for Shell in the whole of Nigeria and the spokesman for Shell in the whole of Nigeria as well. So my family and I had opportunities to different hospitals in Nigeria. So I had good financial support. So I wasn't lacking in that aspect. So when I got diagnosed, I was opportune to get diagnosed by one of the best neurologists, Dr. Shea Roberts, who owns a, I think he owns like a laboratory, at Obalende where people would go for EEG tests and all of that. So that was the first time I got diagnosed with partial complex epilepsy. But people don't usually seek help because, when you talk about admission process in Nigerian hospitals is a lot. I checked myself into the psychiatric hospital in 2015. I think I spent about more than 100,000 naira per week for accommodation, food, and medications. That was just per week. And I was there for a month and 2 weeks. So you can imagine how much all of that would have cost. And then in 2019, when I checked myself in again, there was a patient in the hospital who had gotten discharged, but he didn't have, his mom couldn't afford a hospital bill. So the hospital didn't let him, leave the hospital until all his bills were sorted out. So financial aspects can be one of the challenges why people don't seek help in Nigeria. Another challenge is the lack of social support from your family, your friends, and your neighbors. I actually had this challenge because my family members didn't even understand what was going on. They just thought I was very aggressive at some point, because I was fighting everyone and I was very irritable and all of that. So I was the one that noticed, because I've always loved critical thinking. So I thought about everything. And I remember I was the one that called my dad and said, Daddy, I want to get checked into the hospital. And he's like freaking out and stuff. And I'm like, no, I mean, I'm fine, but I feel like I need help. So at that point, they didn't understand. In fact, one of my sisters told me I was faking it. She said there was nothing wrong with me and I was faking it. You know, my didn't understand. So their family members, and because first off, if you do not understand what that person is going through, there's no how you can offer help to that person. So I had challenge with that. Another challenge we have in Nigeria when it comes to mental health conditions is the fear of stigmatization. So let's look at it this way, right? If you give birth to a child right now, that child doesn't know the difference between good and bad. But that child learns when, you know, his or her parents, how his or her parents train him or her. So that's how it is. And that child is going to grow up with what he or she has learned from the home, right? So imagine if we didn't have anyone talking anything bad about mental health conditions. The people that have mental health conditions would not see anything bad in it with trying to talk about it, and they would not feel stigmatized. So I feel like as individuals, we need to be very careful about, you know, stigmatizing people, because look at it this way. People don't stigmatize people who have cancer or kidney or, you know, all of those diseases. But when it comes to mental health conditions, because you're not seeing it, and because it has to do with the mind, and because you see people who are on the streets with their clothes off and all of that, then you're judging, right? So another challenge is the aspect of stigmatization. Okay, so now let's look at, in my mental health journey, it was very hard to try and learn things from people, because everyone was literally stigmatizing me because I'll be 38 next month, 25th, May 25th, but I started having mental health conditions when I was 17, but I got healed last year, November 15th. So that's 20 years. So this whole journey has been it was very difficult, because if I tell people about my mental status, they call me mad. Someone in school said I was a walking corpse, you know, because she didn't understand what, you know, partial complex epilepsy was. And there's also a myth in Nigeria, you know, people with schizophrenia can be seen, you know, they'll call them witches or ogbanje or things like that, you know. So let's look at things that would have actually helped my journey to be easy with my in life, with the mental health conditions that I had, because everything I learned on my own, to be honest. I had to do research, I had to go for therapy. And even with the therapy, I had doctors that stigmatized and dehumanized me. So it was a very, very difficult journey. There were so many times I was tired of life, and the only reason why I literally didn't kill myself was because I'm a Christian and I read my Bible a lot. And in the Bible, it says, if you kill yourself, you go to hellfire. That is the only reason why I literally didn't take my life, you know, because I was tired of everything. Now, if you talk about things that would have helped me will be the support system, right? So as a friend, if I tell you I have mental health conditions, if you do not look down on me, if you don't dehumanize me and stigmatize me, then I'll be free to discuss my challenges with you and share my journey and my story with you. if my family members actually came to understand later on, but because I also did the work of telling my psychologist and my psychiatrist to come to the house and, you know, educate everybody about what mental health conditions are. Another aspect that can help people with mental health conditions is the community psychiatric care. You know, things like the church and the mosque. You know, so in a church, there are some churches in Nigeria where when someone says they have mental health conditions, they will tie that person and flog that person. I met people like that at the hospital where they were chained for weeks and they were stabbed and flogged with brooms and canes, saying they wanted to cast away the, you know, evil spirits in them because they saw, you know, churches and, the community, the religious community see mental health conditions as, you know, witchcraft and from the devil and all of that. But if we have a, you know, a psychiatric care in churches and in mosques that can literally have bodies, you know, people that can talk to people if you have challenges with mental health conditions, and then they educate you about it. And just like every other illness, when they say, you know, when a church member comes and says he or she has cancer or whatever, they say go to the hospital. If we have such people in the community, in the religious community that can do that, then people would always want to seek help. Another thing with the community is that it can also help correct the stigma associated with mental health conditions, and can also help the community as regards falsehood of the myths associated with the mental health conditions as well. So this also makes it possible for people with mental health conditions to maintain family relationships, friends, and also their jobs, you know. Another thing that can help the mental health conditions, people with mental health conditions with the religious community is that if they get treated on time from the grassroots, you know, with things like emotional disorder, for instance, if people can notice that in their community, then they can start to help people with these conditions. And then it would also now lessen, you know, the amount of people that will go to the hospital for professional proper care. You know what I mean? So the church and the mosques have like a very big role to play. In my own case, I don't think anyone in church knew. I don't think anyone in church knew until after a very long period of time, because I was always having seizures in church and things like that. So at the end of the day, my pastor and his wife got to know about it. And, you know, I thank God for the awareness now. You know, they'll always say, let's pray about it, but go to the hospital, take the meds and things like that. So yeah, those are the things that helped me. But like, I feel like if everybody can accept a role to play in their own community, religious or not, even as pagans or atheists or whatever, if you have a role of not stigmatizing people with mental health conditions, it will go a long way with how people see themselves and how they can also seek help. Because another thing that can make someone not to seek help is because, for example, if I tell you I have so, and then you tell me I'm mad, then I can also stigmatize myself as well. And that used to happen to me a whole lot. I used to self-stigmatize myself with my siblings. I see them laughing and I see them having fun. And to me, I can't do all these things if I don't take meds, you know? So so if everybody has a role to play with not judging people, not assuming things. You see someone who is on the street and on social media, maybe they post a video, everybody's commenting in the comment section on Instagram and saying on colos, oh, drugs. That is a big assumption. But if we do not assume and if we don't judge before we even know what's happening, it will go a long way. Thank you very much.
Thank you so much. Can we give her a round of applause for sharing that story with us? In the comments, in the chat, Aisha, or one of the commentators, said that you were so brave, and I think that you were so brave, honestly, to share about that. I just think I can't imagine what it means to live for 20 years, from 17 to you're about to turn 38, for 20 years, and not have a framework, not have the support systems. You mentioned the challenges, the financial challenges. I'm just thinking myself, people don't even make 100K per week. And that's how much you paid per week when you were in a hospitalized about this. People lack the social support that you mentioned, the stigmatization. And what you mentioned that a lot of people do not say is this issue of self-stigmatization. So it wasn't just an issue of challenges coming with stigmatization, but it's also self-stigmatization. And we really need to think about what you said in terms of roadmap. What would have helped support you, which was being there, not stigmatizing, having psychiatry in the faith community. And I'll say for myself that going through the experience of working on the policy documents, I think that that's one place that we can do better at as a community of stakeholders in terms of incorporating faith leaders from Muslim, Christian, or other faith traditions to make sure that we get this word about mental health in terms of our outreach. So thank you so much. Again, let's give her a round of applause. I think you're so brave for doing that and helping us really get a human face to some of these challenges that we face. And the one other last thing that you said that got me was that you would have taken your life if not for faith. So which is a double-edged sword sometimes in terms of how we experience it. So we really need to make sure that the faith community is part of what we do. And thank you so much for your brave work. I think that really helps set the scene when we talk about not just suicide, but general mental health awareness in terms of what would have helped someone like Sontoye, who's using her voice now to spread the message. So I want to invite back on stage Dr. Ojo, and if he can share some of the major highlights that's going on when it comes to the National Mental Health Policy. Launched at the same time with Suicide Prevention Framework, just focuses on the process of suicidal ideation, etc., that was mentioned by Dr. Atalola. Now let's hear a little bit about the National Mental Health Policy. So Dr. Ojo, if you can make your way onto the virtual stage. And I see also, Aisha, you have a quick question or comment?
Comment, actually, but I'll wait for Dr. Ojo to finish. Thank you.
Okay, we're going to have, after this, we're going to have some group pictures, and then we're going to have some questions and comments from the audience. So Dr. Ojo, if you're there.
Hello.
Hello, sir.
Yeah, my network is becoming unstable. Can you hear me?
Yes, sir. We can hear you. I'm going to stop sharing, and we can hear you now, and you're pinned.
Well, okay. So you want me to make some comment on the intersect of
if you could just give us some highlights about the mental health policy, some things that people should be aware of that are in the mental health policy.
Well, let me just make some maybe quick comments or like maybe a snapshot of what is in the policy. like you said, the policy is available for sharing. The intersect of the National Mental Health Policy, the National Suicide Prevention Strategic Framework, and the National Mental Health Act 2021. So the National Mental Health Act actually specifically made mention of a national suicide prevention strategy. And by the time that we were developing the policy also, or let me say review, the law was already in existence. And so it gave the policy, we will say, like you said, that since post-independence, this is the first policy we will say that has an up-to-date human rights approach based on National Mental Health Act backing a national mental health policy. And so it gives it that legal backing, make it enforceable. And so not just having a policy that you could afford not to do something about. And so the provisions that are in the Act were largely addressed or highlighted in the National Mental Health Policy. And the spirit of the National Mental Health Policy reflect let me say the letters of the National Mental Health Policy reflect the spirit of the National Mental Health Act. Apart from seeing health as a right-based issue and then protecting the right of people with mental health conditions, one of the big thing behind the National Mental Health Act is to increase access to mental health services for people with mental health condition. And so the issue of making affordable and quality mental health services available is part of the philosophies of this policy. And again, people that are privy to the 2013 mental health policy for the country, it talked about a national mental health service delivery policy. And so we were very intentional when we were reviewing the policy that mental health is not, even though in the content, there was some public health approach to it, but in the previous policy, but this was very
His internet is having some issues, I'm sure, but it sounds like it's coming back.
intentional mental health promotion, and all these things that we'll be talking about. If you look at the National Suicide Prevention Strategic Framework, we talked about individual level intervention, community level intervention, and all other strata. So the same thing is what follow in the National Mental Health Policy. If you're talking about mental health promotion, mental health prevention. And so service delivery is just one out of the many interventions. And of course, if we were talking about the guiding principles that was guiding this document, that guided this document, community-based approach, intersectoral approach across lifespan approach to interventions, both in the prevention, promotion, and if we're talking about integration and service delivery, we talked about integration of mental health into existing platform, and we're talking about both vertical and horizontal integration. So we talked about for service delivery and spoke to some of the things that Sotonri was talking about. We believe that we talked about addressing the human resources gap for mental health in the country. We talked about integration across all tiers of government. And so in that, we have mental health integrated into the primary healthcare level and community level. And so when you're talking about the primary healthcare and community level, we'll be talking about community-based organization, peer support group, those one at that level. You're talking about a secondary level of care, these are strategies not just for increasing access to care, but also as a way of addressing the stigma that is associated with mental health conditions. So if you have people that are receiving care in the general hospital setting, you will see that the stigma is reduced. And then at tertiary level, so that at this level, and presently we talk about 10 federal neuropsychiatry hospitals, we talk about the skewness of even the available resources. But going forward, we are saying that we will be very intentional about this. First level, the primary, secondary, tertiary, and then across the disease conditions. And the truth is that we are doing that, just like I've said, with integrated mental health. So we talk about integration of mental health across all other disease programs. We've done that for NTD. Now, HIV, people living with HIV, the coexisting mental health condition, talking about their quality of life. Now, this MH gap that we have discussed, that we have just contextualized, already talking about integration at that level, integration of mental health into HIV. This is what we are doing. But the MH gap, imagine HIV care in the country is in all the 36 states and FCT. And so if we have stakeholders that are working in that space, there are more than 1 million people that are living with HIV in Nigeria. Their mental health conditions not addressed across the spectrum, talking about promotion, prevention, and taking care of the undiagnosed one. Now, look at the uptake of MH gap by all the service provider for HIV care in Nigeria. That is covering over 1 million Nigerians with mental health, providing affordable and quality mental health services for them. Now, talk about at primary healthcare level, the MH gap. We are talking about with the National Primary Healthcare Development Agency. Now we talk about the financial mechanism. The truth is the National Health Insurance Act, there is the vulnerable group provision in the National Health Insurance Act and in the National Health Act too, that make room for 1% consolidated revenue. Mental health, people that have mental health conditions are supposed to be in that vulnerable group. And people that are in that vulnerable group are supposed to do what? They are supposed to be exempted from payment. But the National Health Account data for the country was just presented about 2-3 days ago at the National Health Policy Dialogue that was heard. Guess what? 76% of people in Nigeria are still paying out of pocket. I would say even that has gone up, but that is much more for people that are living with mental health conditions. And so when we had pushing forward for the implementation of the policy, that was why last year when we had that ministerial roundtable is how do we talk about universal health coverage? And financial protection is one of those mechanisms of achieving that. But there are many other ways integration, all these things are taken care of. If we are talking about mental health, looking at it from a very multi-sectoral approach, the Ministry of Poverty Alleviation, humanitarian services, all these were taken care of in that policy on what, who and who should be doing. And of course, COVID actually brought so much on the table for mental health, and we realize how so weakened our system can be. And so again, that document addressed the issue of addressing the mental health and psychosocial support of people in humanitarian setting, not just within pandemics, but during disaster, flood, and things like this. And you know, the intersectorality of it is very much there. And we were also very happy that at that ministerial roundtable, the Honorable Minister for Youth Development was there too. Because one big thing is the mental health of young people. And the truth is, we are very intentional. Mental health of young people is even the most neglected out of all mental health conditions. And we know about all this gap that by age of your 14, 50% of mental health conditions that one would deal with in lifetime has been established. Look at that bracket. And by 24, 75% has been, has been established. Anything that the mental health professional want to deal with in their whole life, 75% of them has been established at that time. And you can see even what Sotoye talked about. When was our first episode? 17. A very productive part of our life. And so not so much is being done for these people. And we believe that there are some very low-hanging things that we can do for policy direction. Something as simple as school-based mental health program. What can we do appropriately at primary school level, at secondary school level, and at university level? They're looking at it from a very step care approach. So these are some of the things that were highlighted in the policy. I can just speak to them generally, and I believe that people can sit down with it, look at it, and just like the policy, the suicide prevention strategic framework, there's something that every one of us can do about it. And when we look at that document, we will see what we can do. And again, something that has been the bane of scaling up development of mental health in Nigeria is that disconnect. Nigeria is so complex. The disconnect from the national level to the subnational level. So we can sit down up there as federal government people and then develop policy for the whole country. But what about the optic? The state, Nigeria is a federal state. So the state have to do something. And so again, matching our policy with policy action, we were able to raise a memo to the biggest decision body for health in Nigeria, the National Council on Health. Because the MH gap that we discussed now, that we just contextualized, Nigeria first contextualized it in 2011. And the National Council on Health did what? Adopted it that the country is going to scale up mental health using the MH gap. But the truth is, they were not up to 2 states that implemented it. And so when we came in 2022, we sat down and said, what is the missing link? There is no mental health structure at the subnational level. There are states that could have pockets of, state psychiatry hospital, but I'm a psychiatrist, but the thing about mental health is more than psychiatry. It's more than taking care of disease. So we made a move to say, let us establish, we presented that memo to the National Council on Health that can we have the creation of the national, can we have the creation of mental health desk across the state of the federation? Because whatever we are doing at national level, then we can step it down. And so I can say that as at our last count, following the approval of the National Council on Health, at least we have 14 states that have created a mental health unit in the Department of Public Health. And again, very intentional about our policy action. We do not want the mental health unit at the State Ministry of Health to be created under the Department of Hospital Services, because that is just going to be about offering services. But when they create it in the Department of Public Health, then you'll be talking about health promotion, you'll be talking about prevention, you'll be talking about multi-sectoral approach to addressing mental health. Because the vision of the policy is to do what? Is to see a nation with optimal well-being of mental well-being of all the people. And so that is very intentional, optimal mental well-being. And so the spectrum of mental well-being, not that we are waiting at the other end and we are just all about service delivery.
Thank you, sir.
Thank you. Yeah.
Thank you so much. Can we give him a round of applause for telling us the amazing things that he's doing? And Dr. Ojo, I don't want you to go away. I actually want us to have some quick questions. And I'm going to invite all the panelists actually to come onto the stage so they can talk. And if there's any questions, Dr. Ojo's here. I'm about to pin Aisha to the stage. If I can add pin, yep. And Dr. Atilola, I'm gonna add you as a pin. I'm gonna pin myself. There we go. Beautiful. So we're all here, and if you guys can turn on your cameras. If you have questions about what you've heard today, if you have questions about the policy, let's just take a couple of questions. I know we're running low on time, but it's because there's so much good information. If there's questions, you can write it in the chat, or you can come off of the chat and just, or raise your hand. I guess that's a better way of doing it. You can raise your hand and we'll call you, or you can write your question in the chat. And while people are gathering their questions, I guess the one question I'll ask Dr. Ojo is that you mentioned that 14 states have created mental health units. When was the memo raised to the National Council on Health in terms of creating those subnational units? And then I see somebody's hand up, but if you can answer that while this, if you can answer that question.
Well, I will say that this memo was actually the first memo I raised when I came into office, which was in 2022, and it was presented at the National Council on Health December 2022, but we could not get the letter signed off until last year. And so the new honorable minister, just before the last National Council on Health, which was held in October, signed those letters. And I tell you, he personally signed the 37 letters by himself. And so we delivered to every one of them. And of course, between then and now, we have at least 14 states. And I can't count them by the finger if you want me to mention. But of course, maybe we will not count Lagos State because Lagos State was already ahead of the pack. But of course, they are in. So, but I can mention
I think
some of these.
I think it's okay. I think that what we'll do is that our team will be in touch with you. It'll be great to get those 14 states. And when we send out an email about next steps from this conversation, we can mention the 14 states in case somebody's in a state that doesn't have it. They can start putting pressure on their structures to get it. I see two hands. Let's start with Binfa. Binfa, if you want to just come off of mute and maybe share your question.
Yes, thank you so much. Good evening. My name is Binfa. It's actually a privilege to be part of the conversation, to hear our panelists talk about, the important things and interesting things that is happening in the field of mental health in Nigeria. Presently, I work in the Northeast, where we support people that are affected by armed conflict. And I think for me, my major challenge is that a lot of things are happening in terms of the strategy, the documents, but one of the major challenges that we have is that you don't really have access to some of these documents. So my own question is, in terms of sharing of these important documents, are there specific plans so that for example, the suicide prevention strategy and policy can actually get down, at the grassroots, so that people that are providing these services at the grassroots can actually have access to them. So you realize that a lot of good things are out there, but information is not really out there for people to really know that things like this are happening. Thank you so much.
Thank you for that. I think let's get the next question, and then we can have panelists answer. So, Mr. Danasi, can you, I see you have your hand up. Can you ask your question? And if you have any other individuals, we're going to take 3 questions. If there's any other person who has a question, please raise your hand. So, Maaga, please share your question.
All right, thank you very much. Good evening, everyone. Okay, so my name is Nazif Danesi, the Technical Officer on Mental Health Advocacy under the Nigeria Medical Students Association. So I'm a medical student, and what we do here is the Medical Students Association has mental health advocacy, and I'm at the head of that office. So, we are medical students, and we have a lot of mental health problems and dilemmas that we don't actually talk about. An exam in my school, and it was so bad that we set up a committee to go around the hostels and looking for people that were going through like probably psychosis or something. So as Dr. Ojo mentioned before, mental health problems develop at the young age, 14 years, 24 years, and we see these things manifest in universities. So normally my jurisdiction is every medical schools in the country. So that's university students. And we see most of these problems happen. But then there's a dilemma we face. It's either people don't know proper mental health care, or people are usually not aware of these things, and they don't know that these services are available. They don't know how to get them. Is there something we can do, or is there for university students in order to, properly take care of their mental health, or to address this issue of mental health problems? Yeah, I'm asking this question as a sort of suggestion, because there's actually a lot that I can do from my office, but I don't exactly know what to do at this point.
Okay, thank you, sir. I think we got the gist of your question. There's a couple of things I want to say. The first thing is, I think it would be great if you shared your contact in the chat, or and also shared your email, or also reached out to us at Nigeria Mental Health. I think we can it would be great to get awareness on these issues using your platform. So we would love to collaborate with that. With that said, we have two questions. The first question was about the documents and getting them out and translating them and sharing them. And the second question was about this in terms of the services to young people and different things like that. So I'll take it to each speaker, and you guys can address whatever question makes the most sense. Dr. Atilola, do you want to start in terms of if you have any thoughts on the questions I was asked? You're on mute, sir. You're on mute, sir.
Okay. I think what I can say is this very step that we are doing today is still part of trying to drive the advocacy to the sub-national and the community level. You may recall that where we started from was to say the country needs to have a framework, but we never argued that a framework is all what is required, but a framework only provides a template. Sometimes this is a work that can last several years, but the framework that is needed is already contained in the strategic framework that has been drawn. So the work of the Federal Ministry of Health, the State Ministry of Health, everybody is already cut out for them in terms of bringing these messages, and in terms of action or intervention programs to the community level. But this is where it starts from. As to the young people, well, again, I always say that there is a lot of activities here and there, but we have not had the appropriate governance structure to pull them together. In fact, while I was preparing the slide today, something just came to my mind, that what if we have a suicide prevention intervention program repository in Nigeria? And what does that mean? Every action that anybody is doing in relating to suicide prevention, put it in form of a protocol, describe what you are doing, where are you doing it, what is your resources, just as a repository. And maybe in the course of that, somebody may look at all those programs as they are running. I just mentioned the youth mental awareness program that we just got the funding for in Lagos. That is something that can go into the repository so that at any point in time, you can have a snapshot of what are the activities that are going on. And when you want to start your own activity, it may be useful to know what is happening around you, what you can leverage on, what you can bring on board, and things like this. These are the kind of things that I think, because, and what am I trying to answer is the point that the medical student was raising, that, okay, so that is one resource. Well, I'm just getting aware that the Nigerian Medical Student Association have a platform like that, because there is also, I am aware and I'm involved in at least one project involving medical student mental health in Nigeria, which is stationed in Ibadan. So some of these things, when we have a network and the Ministry of Health through the mental health desk is one place where that can be domiciled, while everybody is collaborating with that platform, so that at any point in time, even potential funders should be able to ask that, I want to fund a project in suicide prevention in Nigeria. Can I see the repository of what is being done? And it should be available so that people can know that, okay, you know, this is being done already. This is where the gap is. Why not let us fund this gap area rather than funding the same thing that somebody else has done? It's good that the medical student has shared his phone number and all of that. I believe that there are things that as it comes up in the future, one will remember that there is such platform.
Yes,
Thank you.
I have his contact. I have his email. Dr. Ojo, did you want to respond to those questions?
Yeah. Thank you so much. And again, so quickly at the question, dissemination of the policy document. Well, so we've tried to disseminate to an extent. We still have the document, printed copies. The soft copies are available on the ministry website, including also the National Mental Health Act. But one thing again that we are looking at is to, if we get the funding, to invite the sub-national state actors. There is how that helps in a way. So it's strengthening people's commitment. We discuss what are the things that they can go back and start doing. So that's one thing that we are still looking at. And again, on the university students and intervention, you see what I mentioned earlier, like we want to have school-based mental health program. And the truth is, before now, the mental health services available in the university system is a far cry from what it should be. And so I believe that what are the things that can work? We've tried to apply for 1 or 2 grants, which were not successful, and which is like actually targeted at tertiary institution students. And what are the main interventions that we think can work is, one, increase mental health literacy. That is a big thing, which we believe will be quite very helpful. And also a kind of peer support system in the university and polytechnic, tertiary institution, peer support system. This has been found to be very effective. Also building capacity of the healthcare workers at those institutions to be able to respond to mental health need of students. And of course, creating very youth-friendly mental health services. And a very important thing also is the creation of safe spaces in those institutions, you know, which are like maybe using the model of friendship on the bench, which has been found to work very well globally. And so These are things that we believe can work, and also get student initiative to drive some of these processes, leverage on the existing platform. In almost all schools, we have Department of Guidance and Counseling. We can use that as a form of tax shifting, and get human resources available there and get them to be able to offer psychological first aid. And even one of the biggest things, look at what Professor Atilola talked about that happened in Lagos State, data-driven, so we don't have data that can inform decision for the mental health of young people. Even can we begin to collect data when students come into school, know about their mental health, and yearly doing a survey, following up people, and stuff like that. So these are things, quite a lot of things that we can
do.
Talk about the mental health of young people. So
thank you, sir. I know we have Aisha that can also speak to the youth issue. I would like to say to the gentleman from the Nigerian Mental Health Medical Association, we have about 2 to 3 youth mental health organizations that are based in universities. So depending on when you are in Nigerian mental health, and we've partnered with them for walks, etc., like that. So like I said, we're happy to be a resource for you. I see that there's a question, and then I also want Aisha to take this question and then perhaps respond. So Mr. and Miss Adamu, if you want to come off this will be the last question we have. If you want to come off of mute and ask your question.
Okay, thank you, and good evening, everyone. My name is Saadatu Adamu. So this question is directed to Dr. Tunde Ojo. You just mentioned working with counselors, but I haven't seen you do that all this while. I'm sure I've had that conversation with you. I think it's very important to look into that critically. As much as you've mentioned it, it should be one of the things that maybe you should really take into serious consideration, because everyone is, so long as you are talking about mental health, counselors are equally caregivers, and you can't do anything in schools, especially secondary schools, without counselors. So I think maybe it should be one of the things that you should really pay attention to. This is just a question to Dr. Tunde. Thank you.
Can I
do you
quickly
want to take that
respond to
quickly?
that?
Yeah, if you want to take that quickly, and Aisha, we're going to give you the last word before I take a group picture.
Honestly, I don't want to drag this. I don't want to drag this. So I put my words where my mouth is. I know that the counselors came on board at the very last end of the review of the mental health policy, and there were discussions on that. So very clear, using institution-based approach, leverage on available human resources. And I think some of the things that were being pushed at that last meeting was for community-based counseling services. Of course, we know what is in this space. We know what can work. And the truth is, if we want to bring in some new things into the system, the truth is there are initiatives that have talked about training lay counselors at the community level. This we are in touch with what is happening globally. There have been evidence-based intervention, randomized control trials that talked about the role of lay counselors at community level. Nobody's shying away from that. At school level, at school-based level, there are guidance and counselors in those schools. These are things that we will leverage on. But if you are saying what is the role of counselor at the level of primary health care or at health institutions, if you are talking about what's it called? What is the service for them? There is what the scheme of services that we have as a country that has not been entrenched in the system. And if you are talking about workplace mental health, there is place for counselors. If you have seen me where I've been speaking, we have to leverage on what is available there. But clearly, whether I'm talking about it and then whether in implementation, is something that's everything we're doing is so we are public servant, we are public people. Whatever we're doing is out there for people to see, and anything that will turn the needle for mental health. But it's a conversation that we need to have. And what is the role of everybody? Policy way to go, tax shifting, tax sharing, all these things are the things there. There's no people that can say this is just within our jurisdiction and we are the one that's going to do it. It's for us to sit down and have that very frank conversation.
Quick question. What is this the national, is there a national association of counselors?
Well, I think
yes,
I think
yes, let me respond to that. Yes. And I am an ESCO, so yes, I know that there is the Counseling Association of Nigeria, and there's also the Counseling Act. So that also links, the mental health act, absolutely.
So honestly,
okay, ma'am. So can I say this, ma'am? So can you put your information in the chat? I'll tell you that when we were working on things around the Mental Health Act, etc., we had a lot of the leading mental health associations, whether it's we even reached out to occupational therapists. And to be frank, this is the first time I'm learning about this organization, and I will 100% include you in our conversations going forward. If I know about you, I know you've reached out to Dr. Ojo, it sounds like. Can you put your information in the chat? Can you put the name of your organization in the chat as well? And I'll be in touch. My organization will be in touch with you, because Dr. Ojo said it specifically, all stakeholders we want on board.
But the truth is, your person that works for you, Dr. Adamu, he came into the meeting like one of the last 2 meetings. You guys have been represented at the meeting. We are aware that you exist. There's nobody that say you don't exist. Come on, let's talk about other things.
Sorry, Dr. Ojo. No, sorry to correct you. I'm not saying that nobody is saying we don't. I'm just saying it will be good to always have them, because you know why I'm saying. You know why I say this. I'm sorry to just cut you short. I was at the mental health roundtable conversation that the IOM organized, and one of your representatives, which is from the Ministry of Health, was there. And I was the same person who also recommended, because you said one of the plans of the Ministry of Youth is to work with schools. And I made suggestion. I said it would be good to work with counselors. So I'm just saying, I'm just recommending. It's important to always have them, because you can't go into schools without counselors. That's it. We're not going back and forth on this. Mine is just recommendations. Whatever we're doing, it's important to have this. You just mentioned counselors, and that's it. No arguments. We're not arguing. I'm just dropping a suggestion on your table. That's all.
Sorry, if I may just interject as well. If I may just interject as well. Dr. Ojo, I believe it was Chime that mentioned that he had not heard of this organization before, and seeing that you are in contact already with him and know of Dr. Adamu's organization, she was just recommending, as she mentioned, to always carry them along. So nobody was claiming that they do not exist. Chime just mentioned that. Thank you.
And Aisha, do you want to give your final thought, and then we'll do some next steps?
Yes, sure. Wow. A lot has been said here. I have so much to say, and I know this is the end, so I will try to make it as snappy as possible. I've actually written my final words so as to keep to time. So as we draw close to the end of this discussion, I want to express my heartfelt gratitude to each and every one of you for joining us today for this critical discussion on understanding Nigerians' national mental health policy and suicide prevention framework. It's an honor to have shared my personal experience with you and to have listened to such vital topics that really impact the well-being of our nation. I would like to say a special thank you to Chime, the organizer of this, meeting. He is the founder of Nigerian Mental Health. I remember when you started, and it's so great to see the progress that you've made in such a short period of time. Please never be discouraged. In the word of Dwayne Johnson, I found that with depression, one of the most important things is you can realize it, that you are not alone. So please, Shime, you are not alone in this fight. We are all here for you. And your dedication to mental health advocacy is truly inspiring to me. And your efforts are making such a tangible difference in our community. I invited Dr. Adamu to this meeting. She's actually one of my mentors, and she runs a foundation called Secure the Future Foundation. It's great that you want to get in touch with her because she's doing fantastic work in this space that deserves more recognition and more collaboration as well. I want to express my appreciation to the speakers as well who have contributed their expertise and experiences today. Your insights have really enriched all of us and our understanding towards meaningful steps towards improving mental health. You mentioned the Minister of Youth Development present at that event, and I'm glad that we're speaking about young people. The Honorable Minister of Youth Development has made it known while delivering one of her keynote addresses at the African CDC Pre-Youth Conference that she would like to achieve practical improvements in public health in the country. And she reassured members that resolutions from that conference will be adapted in Nigeria. So I look forward to the collaborations between the Ministry of Health and the Ministry of Youth Development. From the records, Africa is the continent with at least 65% of our population under the age of 30. And so I think it's really important that we do this. Why am I advocating for mental health? I'm a media professional, and I know some of you have said, how can you help? How can you help? It starts by sharing a video like the ones that I put out, because research has shown that sharing your experiences can actually help unbuckle some of these mental health challenges that we have. So the media plays a significant role in influencing and shaping behavior. And so you play a part in that story as well. I hope I've answered some of those questions with that. And that is my final remark. Thank you very much.
Thank you so much. And the thing about online conversations, and sometimes we don't record them. We've recorded this conversation. We'll put this out. Dr. Atilola, Dr. Ojo, I would like us to all get on camera and let people take a picture of us so they know, they can tag this and everything like that and smile. Dr. Ojo, if you're still there, if you can come on camera, if possible. If you can come on camera, I don't know if he's in the bathroom. So let's smile, let people take their pictures, and so they know it's not just in person. So
I think it would be nice if everyone put on their camera so we know what they look like.
So we will do that. We're gonna do one picture, just the panel, and then we'll have everybody turn on their cameras. So please smile, folks. Okay, now everybody, if you can put on your camera, please.
Oh, shout out to Khadija. She's my co-host and she's on the meeting as well. Hi, girl.
If you guys can come on, if anybody who can, if you can turn on your camera, I'm gonna put it so everybody is there and we can take pictures so we can commemorate this event. This is history in terms of one of the first awareness event about this policy. So we're taking pictures. Smile, please. Smile. We did really great. So real quick, I want to go through some next steps so people know that this isn't just end like that. Can folks see my screen? Can you guys see my screen?
Yeah.
Okay. So what are the next steps? So the first thing is that suicide is still decriminalized. We got an act. We still need to get a law passed that decriminalizes. And because it's a law according to the criminal code and the normal penal code, we need to try to stop decriminalization of suicide. It's in the suicide prevention framework, but you can still see that it's law. So that means legislators need to act on that. It's something to be aware of. Though it's national strategy that we can use as a tool, we still need to get it decriminalized, as was mentioned earlier. So that's still a challenge, a huge challenge that many people are working on fixing. There's been a couple of things that have been started. Hopefully in the chat, Nigeria Mental Health has started a petition. We have over 5,000 signatures of individuals in the nation calling for decriminalization of attempted suicide. If Elizabeth, if you're there, if you can put in the chat, sign the petition, share the petition with your friends so people know that the government knows when we're advocating that they should decriminalize attempted suicide because the citizens want it and because the new suicide prevention framework says it. Nigeria Mental Health has also launched a policy brief focused on decriminalizing attempted suicide. It explains all the policy rationale for decriminalizing attempted suicide. One of the things you may not know about decriminalizing attempted suicide is that it disproportionately impacts women. In countries where suicide is criminalized, gender violence, and there's increase of suicide rates amongst women. A lot of people don't know there's a gendered impact to our current policies right now. So read the policy brief to inform yourself, and then also read, sign the petition for decriminalizing attempted suicide. I'm hoping that's in the chat. Also, other things you should look forward to is that on either May 9th or May 16th, we have done a policy brief focused on mental health and the elections. I don't know if you were like me, but a lot of people had challenges during the mental health and elections. So we'll be doing a policy brief about how do we mainstream psychosocial care and services into the mental health landscape. That'll be on May 9th or May 16th. If you got this, if you signed up, you'll get an email, but mark your calendars the same time. Likely it'll be May 9th. And then finally, I think somebody's okay, great. Finally, we are doing a lot of work. If you have a policy and plan, you need to have a critical monitoring and evaluation framework. We have some of that, but we need to do more and make it more robust in the suicide prevention and suicide framework. So Nigeria Mental Health is working on thinking through robust monitoring and evaluation and impact frameworks. We're having conversations and we'll be putting out policy briefs about making sure that the governance architecture, the data collection systems, the evidence, and the monitoring evaluation is very robust. As a critical next step, we've had conversations with the World Health Organization. We're having conversations with think tanks, et cetera, like that around the world. And this is something that a lot of countries, not only Nigeria, but even in America, they're thinking about how do we make robust monitoring and evaluation, and what can we learn from Nigeria's story so far. So we're going to make sure that we put together these best practices so not only countries can learn from our experience here. Finally, people have mentioned that if you have challenges or trouble on Nigeria Mental Health, not only can you access these policies, the suicide prevention policies and the framework, but we also have a list of crisis hotlines if you need somebody to talk to. Our partners within the network host hotlines. There's also states like Abuja and Lagos that have government suicide prevention hotlines. We want a national one according to the new policy, but you can use what we have right now to at least get you some help or to share those resources online if you just contact us on our website. And then finally, make sure you follow us. If you want to know, if you want to stay connected, if you want to continue to be engaged, follow us. You'll hear our updates. You hear what we're up to. We respond to every message we get. We have people who want to partner every day, and we are always willing to collaborate. You can find us on Nigeria Mental Health, Facebook, Twitter, Instagram, YouTube, LinkedIn. Wherever you are, we are. Make sure you follow us. And then if you want to reach these resources that have been mentioned, they're on the Federal Ministry of Health website. They're also on our website, www.nigeriamentalhealth.org. We would love to collaborate with individuals going forward in the future. And with that, I want to thank everybody for coming. These resources are in the chat. So if you want to connect with us or this information, please check in the chat for how to sign the petition, how to read the policy documents, and also how to connect with us on social media going forward. And with that, I really want to thank everybody for coming to this important conversation on understanding the new mental health policy and suicide prevention framework. Thank you so much again to our speakers, the Federal Ministry of Health, and all of you, the audience, for attending this important conversation around psychosocial well-being today. Thank you, everybody. Thank you so much.